Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy!
Welcome to another episode of The Fellow on Call, the Hem-Onc podcast. We're coming at you from Merlot University Medical Center. I'm Ronak.
I'm Vivek.
And I'm Dan.
And in today's episode, we continue on our discussion about venous thromboembolisms, and this time we've been alluding to it, but we're finally getting to talking about antiphospholipid antibody syndrome.
I'm really excited about this episode. This comes up all the time. Nobody knows what it means. We're going to decode that for you. I will make one plug. If you're concerned about it, just put the patient on warfarin. They're going to need anticoagulation anyway. Test later. The inpatient testing has a lot of false positive results. It's not the time to test for these patients in many cases. But just wanted to throw that in at the beginning of this episode. By the end of it, you'll understand why.
So much to talk about here. I'm very excited. Let's do this.
All right, guys, let's roll that show. Last time I asked you all about what you guys were planning on doing for the spring. I'm just curious, anything fun that you've been doing recently? It is Tuesday. Anything fun happened this past weekend?
Yeah, we had friends in town. It was great. They stayed with us. There's a couple of friends who have young children, and that's always a unique experience for us because we don't otherwise do all the child-oriented activities in town. So I got to go to the zoo this weekend. Got to go to Adventure Science Center, which is another great museum in town.
Dan, I was also at Adventure Science Center. I just want to point that out there. I was at a toddler's birthday party for one of our friends, and that place is amazing. What do you think of it?
It's so cool. It's so the heart there has undergone a Lima to LAD bypass, or actually it's a Lima to OM1, I think, which is a little bit funny. They clearly just had a picture of a heart and made the model off of that without realizing that it was not normal anatomy. But otherwise, very good.
And the mannequin there in the medical station, notice how we're just jumping to the medical station and ignoring the solar system, though that was cool too. They did a really good job. They showed James Webb Telescope. I'm like, this is amazing. Kids should learn about this. It's like crazy. But in the medical exhibit, because this is a medical podcast, I guess, there was a mannequin there and he had a thoracotomy, he had an X-lap, and he broke his tibia. And I'm like, wow, this is just hitting on all the trauma high points. I'm like, this man went through it. This is a serious trauma case right here.
That's pretty cool, guys. I did not go to a science museum, although there is a pretty cool museum called the Please Touch Museum, which I think is sort of a children's adventure museum in town.
That's not a good name.
I
know,
name
for one of those things.
And I'm intrigued by it, but Jan has said that we should probably go when we have friends in town that have children so we can go with them, because it's weird for two 30-something-year-olds to walk into a children's museum called the Please Touch Museum.
Yeah,
bring hand sanitizer, either way.
Yeah. Other than that, I will say one of the birthday gifts that I got this year was a chef's sushi knife. And so there is a local vendor in town that sells sushi grade fish. We were able to purchase a lot of really, really, really high quality fish this past weekend, and we made poke bowls and homemade sashimi, did a little game night with all of our siblings that we're fortunate enough to have live right in and around where we live. So super fun, and it was fun to get to use our new toys. We have been alluding to this for the last few episodes, and we're finally here getting to talk about antiphospholipid antibody syndrome. If it's okay, I'm going to give you all a case this time. This is a little bit out of character. I haven't done this in a while, but I think this will set the stage for what we're going to discuss in this episode. So y'all game?
Yeah, let's do it.
So we have a 35-year-old woman who had no significant past medical history who presented to the emergency department with sudden onset of shortness of breath. She had pleuritic chest pain and a sensation of impending doom. She had denied recent travel, denied any surgeries, immobilization, or use of hormonal contraceptives, all those provoking risk factors that we have talked about. On exam, she was tachypnic with mild tachycardia. Her oxygen saturation on room air was 92%. And so the ER had checked a D-dimer, which was markedly elevated. They performed a CT-PE on her, which confirmed a segmental pulmonary embolism. Given the absence of provoking factors, an extensive hypercoag workup was initiated while the patient was admitted by the primary team. And as part of that, she was noted to have negative lupus anticoagulant, negative anti-beta-2 glycoprotein for IgG and IgM, but she had a positive anticardiolipin IgM antibody at 53 MPLs, which is the units for it, but a negative anticardiolipin IgG. And don't worry, guys, we'll explain what all this means in this episode, but just know that she had positivity for anticardiolipin IgM. So, of course, now they have these abnormal results, and so they call their neighborhood hematologist for guidance about concerns for antiphospholipid antibody syndrome. So let's start here. This idea of could patients have APLS comes up all the time. So first and foremost, can one of you just explain to us, what is this diagnosis?
Before Dan gets into an explanation of what this diagnosis is, please check out our hypercoag episode to understand when to send these testing in patients. It's not something that you need to send in every single patient. Check that out, because you'll see in here, if you look at our recommendations in that episode, we wouldn't have necessarily tested it. And there's a lot of reasons for that. And we'll get into the risk of a false positive test here. But Dan, I just had to plug that in. It's a gripe of mine. It's really important for people to know clinically when do you send these tests off. So Dan, can you kick us off then with exactly explaining what this is?
Yeah, like you said, it's important to distinguish. Just having the antibodies is different than antiphospholipid antibody syndrome, right? And it's not the same as lupus, even though lupus anticoagulant is right there in the title of one of the tests. The syndrome, it's basically a systemic autoimmune disease that is characterized by thrombotic or obstetric complications in the presence of a persistently positive antiphospholipid antibody. So that means that we have to detect the presence of those antibodies on multiple occasions. The syndrome is often associated with other autoimmune diseases, but this is not always the case. The pathway by which these antibodies contribute to thrombosis is pretty complex and is likely multifactorial. We'll get more to that in a second. The main tests that we worry about are the lupus anticoagulant, which is a functional test, and then anticardiolipin antibodies and anti-beta-2 glycoprotein antibodies. We believe these antibodies target beta-2 glycoprotein 1, which is a plasma protein that binds phospholipids. When the antibodies bind to beta-2 glycoprotein, it promotes dimerization, which then causes an upregulation of prothrombotic cell adhesion molecules, decrease tissue factor pathway inhibitor, TFPI, decrease protein C activity, and even some complement activation. Altogether, this creates a pretty strongly prothrombotic environment. It's important that when we're discussing APLS that we also remember the presence of the antibodies actually increases the risk for both venous and arterial events. So that's pretty unique in the world of prothrombotic conditions.
So Ronak, I went on my soapbox of why we shouldn't necessarily test for these antibodies just in willy-nilly. We should really test for it when it's going to change our management at the right time. And why is that, Ronak? What is the prevalence of these antibodies in the general population?
Absolutely. And this is why you will hear differences of opinion about the optimal time to test these antibodies. In general, we don't know the exact prevalence because there isn't good population-based studies to evaluate this. That being said, there was some studies that looked at, for instance, healthy blood donors, and they said that they found that 10% of healthy blood donors actually had positive anticardiolipin antibodies in circulation, and 1% were positive for lupus anticoagulant. In most of these patients, less than 1% are still positive for these antibodies if you check again in a year. The prevalence in other patient groups is likely higher. One analysis suggested that 20 to 30% of patients with lupus have persistently moderate to high risk antibodies in circulation. 6% of patients with pregnancy complications without a history of autoimmune diseases may have these antibodies. 10% of patients with thrombosis, 11% of patients with MIs, and 17% of patients with strokes less than the age of 50 may also have these in circulation. The caveat with these data are that these studies included patients who were positive once, but they never rechecked antibodies and/or these patients were borderline positive. So overall, what we're seeing is that you can find them if you're looking for them. What to do with that information, though, isn't quite clear. And that's why we don't test unless we have a true reason to go looking for them. And we also don't test unless we think it's going to change our management. And I will say overall, these studies do suggest that the presence of these antibodies is more common in biologic females versus males.
And Ronak, that's really important that you mentioned that these antibodies are very prevalent. And you also noted that some of these were borderline positive when you gave those prevalences within each of those groups, because when we really think about a diagnosis of this APLS syndrome, there's clinical criteria and there's laboratory criteria, but just having a borderline positive antibody is not what we're talking about. We're talking that you're greater than the 90th percentile, you have a very, very high level of the antibody, and all of these are really important that we'll get into. So if the antibodies can be found in the general population of patients and can be false positives, and these aren't always clinically relevant, who should we consider screening for APLS? And what's the optimal time point to do this?
You do want to consider checking in patients who are younger, on the younger side, so less than 50 years old, who have otherwise unexplained thrombotic events, either venous or arterial, or who have microvascular disease. So things like end organ dysfunction, evidence of microvascular compromise. In patients who have adverse outcomes related to pregnancy, severe preeclampsia or placental insufficiency, those folks also probably warrant testing. There's some other supportive findings that can make APLS a little bit more likely. These are things I've actually had referred to my clinic for just one or two of these findings, and someone's like, evaluate for antiphospholipid syndrome. I always kind of wondered why that was, but then the more you read about it, this is something that there are these associations. So things like levator reticularis, that modeled sort of pattern on the skin, valvular heart disease, especially non-bacterial thrombotic endocarditis, pulmonary hemorrhage, thrombotic microangiopathy affecting the kidney, neurologic findings with cognitive deficits and white matter lesions, and some of these findings showing up in a background of somebody who has lupus, that should also raise your suspicion for antiphospholipid antibody syndrome. There may also be some abnormal labs that can elevate your suspicion. One of these is prolonged APTT. Remember, this is why it ended up getting called a lupus anticoagulant, because it makes the APTT look prolonged. False positive VDRL or RPR testing, so false positive syphilis testing. Technically, unexplained thrombocytopenia is in this group. It's not my practice to send antiphospholipid antibody tending for thrombocytopenia alone. As you remember from our numerous episodes on thrombocytopenia, there are like a million things that can cause this, so I don't think it's worth looking just for that. But if there's thrombocytopenia in the setting of some of these other symptoms, then yeah, you can consider that as well.
And Vivek, the latter half of your question was asking about the optimal time to test these. And I will say that there is not good guidance about what to do with regards to timing. Yes, there is a false positive risk that you run, especially if you, for instance, check these antibodies in the setting of an acute clot. These patients are hypercoagulable. There's a lot just going on, and the presence of these antibodies may just be a false positive. I think it depends on who you ask in different institutional practices. So definitely talk to the people that practice at your center to figure out what the culture is. At Rouleau University, we typically didn't test on the inpatient side because it was strongly felt that it didn't change management. Where I work now, it is actually more common for people to check on the inpatient side, and the rationale being that if somebody is positive, then that is somebody that you would want to consider discharging on warfarin as opposed to another agent. And I can understand where that rationale is coming from. So sort of figure out what the practice pattern is for your institution. There isn't great guidance. Just know that there's a chance it's a false positive in the acute setting. And most importantly, as we'll discuss, there needs to be a plan to repeat that testing in the future in order to confirm whether or not that positivity is remaining.
And we're going to come back to this pros and cons debate. I'm going to debate the side of not testing, and Ronak will debate the side of testing after we run through the data. We'll leave our listeners that because I think it's really, really important. Another thing that Dan had mentioned there is that an abnormal APTT, that should maybe prompt you to consider that the patient might have APLS. It's important to keep in mind that that's not the end-all be-all. There are patients with a normal PTT and do not have APLS. It's something that might trigger your mind to think, okay, this patient with unexplained thrombosis and elevated PTT, maybe they do have this, but it's not the end-all be-all for that. So it definitely sounds like there has been a lot that went into the discovery of these antibodies and this diagnosis. Can one of you take us down one of our good old brief history lessons? It's been a while since we've done this. You know I love this. It's near and dear to my heart, where everyone tunes out. So who wants to give us a history lesson on APLS?
Well, this story dates back all the way to the 1960s when hematologists first observed what we call the lupus anticoagulant. Obviously a horrible name because this is a prothrombotic condition, but it's an antibody that was paradoxically associated with blood clotting, but seemed to affect the clotting tests in such a way as to make them look like the blood was too thin. Despite that, the antiphospholipid syndrome, as its own distinct clinical entity, wasn't recognized until the 1980s, when researchers identified anticardiolipin antibodies and their link to thrombosis and pregnancy loss. Antiphospholipid antibody syndrome, or APS, research can be divided into 3 key periods. There was the observational period in the 1960s to 1983, with just initial case reports describing clotting abnormalities in patients with a diagnosis of lupus. The second phase is exponential growth. So this is where a lot of discovery happened between 1983 and 1995. This is the era in which the anticardiolipin test was developed and a surge of APS research followed. Shortly after the discovery of this anticardiolipin test and this anticardiolipin antibody, there was an explosion in the number of publications claiming that patients had this disease. It was known, however, that the methodology to actually get this assay result, basically how people were testing for this antibody, was not uniform across centers. And there were increasingly concerns that we were assigning this diagnosis to patients who otherwise wouldn't necessarily meet criteria. And so there was a push to standardize the assay because of this. There was also a push around the hematology community to create more stringent diagnostic criteria as to what constituted positive testing. So in the 1980s, a committee within the International Society of Thrombosis and Hemostasis, or ISTH, was formed to try and formalize this. It was largely due to these efforts that we identified that IgM and IgG were the isotypes of interest associated with these thrombotic events. And it's also important because of the later definition that we'll sort of develop and we'll talk about. The group also looked to standardize what the clinical criteria were, since this is really important for our present definition. It can't just be the lab criteria. We need to understand that there are clinical consequences to these findings as well. Another thing that was going on during this exponential growth period was a new discovery in the early 1990s that showed that beta-2 glycoprotein 1 might also play an important role in the process. The third phase is the refinement and classification phase. So that's from 1995 all the way up to present day. This is the era where we have more structured diagnostic criteria established to help define this disease. In 1999, experts from a variety of different disciplines came together in Sapporo, Japan, to try and standardize the definition. What they came up with was clinical criteria, so they had to have at least one of these 2 criteria, either a pregnancy loss or a thrombosis diagnosis, and lab criteria, and they had to have one of 2 lab criteria, either a positive IgG or IgM, anticardiolipin at levels greater than 40, and that's either GPL or MPL, and or a positive lupus anticoagulant. And the test had to be positive at least 2 times, at least 8 weeks apart. In 2006, they revisited this, and this updated criteria became known as either the Sydney criteria or the revised Sapporo criteria. They added IgG and IgM beta-2 glycoproteins, and they also adjusted that time frame. So now we have to have persistent positivity on 2 tests at least 12 weeks apart. In 2023, the American College of Rheumatology and the European Alliance of Associations for Rheumatology came together to create a new definition. This is a much more extensive list of criteria than the Sydney criteria. And the important caveat here is that this was an expanded list to try and include more patients in rheumatologic studies related to APS. At least anecdotally, the definitions that came out of this latest update have not been regularly adopted by hematologists. When I'm looking at things and trying to make this diagnosis, I stick with the revised Sapporo criteria by and large.
That was a good trip down history to just understand where we're at today with the antiphospholipid antibody syndrome. Rhoda, Dan had mentioned there, we have these criteria, and part of the clinical criteria, when we talk about those Sapporo criteria, and it's been since revised, but he just mentioned thrombosis and pregnancy loss. Can you get a little bit more detailed about those clinical criteria, and can you also get a little more detailed on that lab criteria?
Absolutely. So this will sort of serve to answer Vieg's question and then just sort of summarize where we're at in 2025 with these criteria. So the clinical criteria are either vascular thrombosis or pregnancy morbidity. And so vascular thrombosis is defined as one or more arterial, venous, or small vessel thrombosis other than superficial venous thrombosis in any tissue or organ. So remember, this is arterial or venous, so it's important to ask about both of those issues. There can also be pregnancy morbidity, and so this is one or more unexplained deaths of a morphologically normal fetus at or beyond the 10th week of gestation with normal fetal morphology. That's been documented by ultrasound or by direct examination. So really, really wordy, but basically there can't be something like a chromosomal abnormality that explains why the fetus had otherwise had fetal demise beyond 10 weeks. And also, it can include one or more premature births of a morphologically normal neonate before the 34th week of gestation due to issues related to eclampsia or severe preeclampsia or recognized features of placental insufficiency. Another pregnancy-associated morbidity that is included are 3 or more unexplained consecutive spontaneous abortions before the 10th week of gestation without maternal anatomic or hormonal abnormalities, and paternal and maternal chromosomal causes have been excluded. So multiple consecutive spontaneous abortions. These are the clinical criteria that are required in order to meet the Sapporo criteria, or the Sydney criteria rather. There's also those laboratory criteria that we've been talking about. This includes a lupus anticoagulant that's present in plasma on 2 or more occasions at least 12 weeks apart, detected by the guidelines set forth by the ISTH. The other criteria include the anticardiolipin IgG and or IgM isotype in serum or plasma in medium or high antibody titers. And so this is going to be reported as a value greater than 40 or greater than 99th percentile on 2 or more occasions at least 12 weeks apart by a standardized ELISA. The third laboratory criteria can be the presence of anti-beta-2 glycoprotein 1 antibody, again in either the IgG or IgM isotype in those same medium to high antibody titers on 2 or more occasions at least 12 weeks apart, measured by standard ELISA. So again, just highlighting, you need both clinical criteria and lab-based criteria, and it's not enough just to say they're positive. You have to confirm whether these isotypes are IgG or IgM in the case of beta-2 glycoprotein or anticardiolipin. They have to be titers greater than 40, or if your lab reports it as a percentile, greater than the 99th percentile. Lupus anticoagulant can also be one of the criteria that's persistently positive, and all this has to be 12 weeks apart. Dan did mention the ACR-EULAR criteria, this much more sort of extravagant list of things that people can meet in order to be diagnosed with APLS. Remember, the key point there is that these criteria were created largely because we're trying to include more people in studies, so they're a little bit more sensitive but a little less specific. There's just a lot more included in all of that. We'll include those criteria in our show notes for your reference.
So thank you for going over all that. That's really good to know, and those details are important for making this diagnosis. There's a lot of confusion generally out there about how these tests are run and how those results could be affected by a patient's current clinical situation at the time the blood was drawn. So just briefly, could one of you tell us how the tests are performed and what those influences are that make it tricky to time this right?
Keep in mind that when you're testing for antibodies, your anticoagulation is not going to affect that. It's not a functional assay test. So the anticardiolipin and the beta-2 glycoprotein IgG and IgM studies are ELISA tests, and anticoagulation is not going to affect that. The challenge is you're going to have a lot of false positives in the setting of an acute clot. So whether that's going to change your management or not is up for debate, whether you should trust to hang your hat on that or not. The lupus anticoagulant assay, however, is a functional assay, so anticoagulants can definitely affect this. This is essentially like the PTT test that we all know of, so we know that anticoagulants are like inhibitors that can interfere with this testing. Certainly, it would be ideal to be able to test for APLS off of anticoagulation, especially DOACs, but in many cases, this isn't feasible, so it's important to not over-rely on these tests, but also use your best judgment. Warfarin, on the other hand, compared to DOACs, it's not really an inhibitor, right? Heparin, a DOAC, that's an inhibitor of some of these clotting factors. Warfarin, though, just decreases the level of clotting factors, and it's less of a problem when we're running this test. And the reason for that is a mixing study could be performed where you just add in factors that could correct for the issues that warfarin is causing on that PTT test. All this is to say is it's a temperamental test that we need to interpret these results with a grain of salt. It requires very specialized coag lab to run these tests. If you really want to know more details on what to order in order to say somebody has a positive lupus anticoagulant, the following criteria must be met. there should be demonstration of a prolonged phospholipid-dependent screening test, such as the dilute Russell Viper venom time or the PTT lupus anticoagulate, the PTT-LA test. And these assays use low phospholipid environments and therefore are more sensitive to a lupus anticoagulant. Mixing patient plasma fails to correct the prolonged screening test, suggesting an inhibitor over a coagulation factor deficiency. An addition of excess phospholipids corrects the test, suggesting phospholipid dependence. So one thing that becomes confusing now, I just used a whole bunch of words there. I just talked about mixing studies, false positives, false negatives. Let's talk about how you actually identify a lupus anticoagulant test. So we think about and I'm just going broad strokes here. If we think about doing a PTT test, for example, or any test, what do? Well, we get the patient's serum, which has their own endogenous clotting factors or potentially drugs that could inhibit the clotting factors like a DOAC or a heparin, and we mix that in a tube that has phospholipids and other things that are important for making a thrombus. And one of those important components to make a clot is a phospholipid. Well, let's say that I had a patient who had antiphospholipid antibody syndrome. Well, what the lupus anticoagulant means is that literally we have an antibody against phospholipid. If we have something in a patient's serum that's binding up all the phospholipids in that tube, then what's going to happen? It's going to take a lot longer to form a clot, right? Just because you have less phospholipids available. So by virtue, your PTT is going to be prolonged. This is why at baseline, patients might have a prolonged PTT, because you have an antibody against phospholipids. The testing uses phospholipids, and so if you've got phospholipid bound up in the tube, it's going to take longer for you to form your clot. The special tests that we do for lupus anticoagulant are things called dilute Russell Viper venom time, or the DRVVT, or the PTT-LA, and these tests are very unique. What they do with these tests is that you're able to use low phospholipid environments, so they're way more sensitive, meaning that if you had any tiny amount of this phospholipid antibody, then it would cause a prolonged test because there won't be excess phospholipids left in the tube to overcome the antibody. So you'll have a more sensitive way of detecting a prolonged clotting time with these tests because of that. And what you can do at that point is you can say, well, is there something that the patient has in their system that's causing an interference? Is it a fact that they've got antibody against phospholipid, or do they have some sort of factor inhibitor? You can actually test for something like a low molecular heparin weight level or an anti-10A level, and that'll tell you, do I have Lovenox in my system? Do I have a DOAC in my system? Once you rule all that out, if you have a prolonged test with only a tiny amount of phospholipid in there, then you know that probably the patient's antiphospholipid antibody or their antiphospholipid component is causing an issue. Why warfarin works is because you can just do a mixing study. You can mix in normal clotting factors, and when you mix in the normal clotting factors, you raise those low factors that were related to warfarin. So sometimes you can do this test on warfarin. You can't do the test on DOAC because you have an inhibitor of the assay. You have an anti-10A there. Can't get rid of that. No matter how much you mix in there, you're not going to fix your problem because you have an inhibitor present. And really what you're asking is there a extreme sensitivity to an antiphospholipid antibody? And that's what the test is looking for. That's what we're saying when we think about this. And when we add excess phospholipids to the tube, then we can actually correct the test. And that tells you that you have some antibody in the system that was binding up all the phospholipids that were there now, but now that I'm adding a bunch of extra phospholipids to the tube, suddenly I have a clot formation. So I've used up all the antibodies that the patient had in their serum. So that tells you that you have a phospholipid-dependent process and that you have a lupus anticoagulant or an antiphospholipid anticoagulant is really what we're talking. It's not really an anticoagulant, it just prolongs the test. And that's the misnomer here, because in the body, it's not preventing you from forming thrombus. In the tube, it is, because the test requires phospholipid for clot formation, and you're just measuring the time it takes for clot formation.
So well said, Vivek. I think that listeners, go back and take a listen to this a few times. This is often very, very confusing. People don't understand this. What I do want to highlight, and I think maybe next time what we can do, over the last couple of weeks, we've been talking all about different types of anticoagulants. I think we bring this all home and try to discuss how we use this information to guide anticoagulation management for patients with APLS, thrombotic APLS in our next episode. But just to recap what we discussed here, Remember, in order to make a diagnosis of APLS, patients must meet both clinical and laboratory criteria that are reproducible, at least when it comes to laboratory criteria, in order to meet this diagnosis. And if your lab for some reason doesn't report titers, you must ask them to give you titers. It is only IgG and IgM that are important for beta-2 glycoprotein and anticardiolepin. IgA does not matter. And I alluded to this before. These antibodies must be repeated 12 weeks apart. You can't tell somebody that they have antiphospholipid antibody syndrome unless these tests are repeated. So, guys, any final thoughts there? I'm looking forward to bringing all of this home in our next episode.
I thought that was great. I just want to point out Dan is now wearing a white coat, a t-shirt, and a stethoscope. No idea why, but that was a great wrap-up, Ronak. I agree with everything you just said.
It was. No, I have to jump on another meeting where I have to look slightly more like a doctor than I do for these recordings. So figured that I'd at least go for the Dr. House look.
I love it, Dan. I love it. So we'll let you get to your meeting. Listeners, thanks for tuning into another episode. Next week, we wrap this whole conversation up talking about anticoagulation and APLS. Until then, we'll see you all later.
See you later.
Peace.